So chapter 6 is discussing nursing care of patients with fluid, electrolyte, and acid-base imbalances. The first couple pages is going into biology, where it's talking about fluid balance, it's pointing out different terms as it relates to intracellular fluid, extracellular fluid. What are the difference with intracellular fluids and extracellular fluids?
Intracellular is in the cell and extra is outside the cell?
Correct. And it talks about intravascular fluids, where anytime we hear intra, we know intra is inside of something. Vascular is the vascular spaces such as capillaries, arteries, veins, those types of things. It also talks about control of fluid balance. It's talking about anti-diuretics. A diuretic typically makes us urinate. People who take diuretics are receiving diuretics to pretty much rid the body of excess fluid. And anytime that you hearing the word anti mean it's against it. Anti mean it's against it. So it's against diuresis, which is rid in the body of fluids. So an antidiuretic will continue to contribute to fluid retention, where your body is actually retaining fluids. So our body do secrete antidiuretic hormones, and those hormones will cause us to retain fluid. In some situations where patient is dehydrated, where patient is hemorrhaging, where they're losing blood or something like that, your body, different body mechanisms will kick in so that you won't lose so much fluid. Antidiuretics will be secreted to actually prevent the fluid loss. And it talks about the term osmolarity, where osmolarity refers to the concentration of substances in our fluids. What is the quantity of substances that we have in our intravascular fluids or our interstitial fluids. And it just talks about isotonic osmolarity, where different isotonic fluids, the osmolarity is equivalent to our blood. And isotonic fluids that you will learn about is solutions such as normal saline. A lot of times as nurses, when we like doing wound care, we cleaning somebody's wound, or a patient is dehydrated, the physician will use some type of isotonic fluid, or nurses. So if we clean in a wound, we want to use normal saline. It's a sterile solution that we will actually use to clean. And isotonic solutions has the same osmolarity as the human blood. And it's talking about fluid gains and fluid losses. Okay. One of the things that I actually point out is that as human beings, we can survive some time without foods. We can survive some time without foods, but if we're deprived of water for a few days, we will actually die. So the body definitely needs water. It's also pointing out sensible losses, sensible and insensible fluid loss, where sensible fluid loss are those fluids that we're actually aware that we're losing. And that can be from urination, that can be from like diarrhea, those types of things. Insensible fluid loss will be the water that's actually eliminated in our feces. Insensible fluid loss, when we are breathing, we're blowing out, we're actually losing fluid. We're losing fluid. When we sweat, we're losing fluid. Those are considered insensible fluid loss. Now, some people consider sweat perspiration as a sensible fluid loss, because to a degree, for a nurse just to say, if a CNA then reported to you, hey, for the last 2 days, Miss Rogers been sweating. You know, she didn't wet up her whole sheets with as much sweat as she been sweating, those types of things. So it's kind of like measurable to say, but perspiration per this book is considered an insensible fluid loss. And it's talking about fluid imbalances, ads for dehydration. Who are some people that you all can think of that are at high risk for dehydration?
Patients who are hypovolemia, who has hypovolemia, or diabetics.
Yeah, well, hypovolemia will kind of run hand in hand to dehydration. And you say diabetics. Diabetics could potentially be at risk, but not really. Because with diabetics typically have 3 symptoms, and it's the 3 Ps: polydipsia, polyphagia, polyphagia, and polyuria. And the polyuria is where diabetic constantly urinate. The polydipsia is that thirst, that they're constantly thirsty, so they constantly drinking fluids because they constantly urinating to kind of keep that fluid balance. But I think about the confused people who are confused, where they are at high risk for dehydration, because if you actually confused, you may not know if you hot or cold. You don't know if you're thirsty or not because of the fact that you are confused. You have some patients who are bedbound, who are at high risk, patients who really cannot advocate for themselves. The elderly population is at high risk for dehydration. And even as future nurses, with the weather being like the temperature that it is now, it's really important that you are communicating with your CNAs and that you are ensuring that water is being passed to your patients. And it talks about dehydration. Dehydration occurs when there's not enough fluid in the body, especially in the blood, which is considered the intravascular space. And it points out this decrease or loss of fluids is referred to as hypovolemia. So when your blood volume is low due to dehydration, it will be considered hypovolemia. You have low fluid volume. And then to think about some ways to prevent dehydration, what are some ways that you all can prevent dehydration?
By offering water to the patients who are confused often.
Definitely, yeah. And even anticipating your patient needs. You recognize your patient is experiencing nausea and vomiting. Patient hasn't been eating due to the nausea, due to the vomiting. When the patient try to drink fluids, they're constantly throwing it back up, where you do want to offer fluids, but eventually if a patient experiencing nausea and vomiting and it results in dehydration, patient will be placed on IV fluids. But you also want to ask the physician, if you recognize my patient is experiencing nausea and vomiting, it can contribute to dehydration. Hey, is this a medication we can get this patient to suppress those symptoms? Your patient experiencing diarrhea. Diarrhea can contribute to dehydration. You want to educate your patient on increasing a fluid intake unless it's contradicted. So as nurses, we are educators. We definitely educate as nurses because there are a lot of patients who don't understand their new diseases. A lot of patients don't understand how to care for themselves with these different diseases. And as nurses, student nurses, as we recognize it, we want to educate those patients. And it talks about the signs and symptoms of dehydration. And some of the signs and symptoms of dehydration, some of it we already know, where your skin's starting to look dry. You know, some of the basic signs, you know, your mucous membranes appear dry. Your skin turgor. How do you test for skin turgor?
When you pinch the skin.
Yep, and typically we some people we pinch over the sternum, and we know the sternum is that the bone where the ribs are connected to in the middle of our chest. We can pinch over that area. If it remained tented, where we pinched it and it still got that pinch sitting there, that is a sign of dehydration. That is a sign of poor skin turgor. Patient skin turgor remain tented. But typically, if we pinch somebody's skin, even if we pinch over our hand, the back of our hand, you know, we pinch it, and then our skin recoil back to the normal form. But with dehydration, that tent will actually stay there. Some people's eyes can become bulk due to dehydration. So you just want to be vigilant for signs of dehydration. Patient urine output is less than normal. What is the normal urinary output per hour? What is the normal urinary output per hour? So the normal urinary output per hour is 30 to 50 mLs an hour. And I know in fundamentals of nursing too, you all covered this material. The normal urinary output is 30 to 50 mLs an hour. How do an ml actually look? How do 1 ml look?
A drop.
It's a drop. A ml, a cc, and drop all mean the exact same thing. So 1 ml looks just like 1 drop of water. 30 mLs look just like 30 drops of water. And it's kind of important to understand how these different measurements look. So when you do have orders from the physician, hey, get that patient 30 mLs of Prostat, or get that patient 30 mLs of Robitussin, well, you can kind of picture exactly what 30 mLs will look like. So we know 1 ml look like 1 drop, 30 mLs will look like 30 drops. So in an hour, the human body should be making 30 to 50 mLs a urine an hour. As a nurse, if I'm providing care for a patient and I'm ruling out dehydration, I'm going to monitor this patient urinary output, because that's an indication of dehydration. Let's see how much urine this patient is producing. And in an 8-hour period, what should be the minimum amount of urine a patient actually produce?
16 ounces.
Would that be 16 ounces? No.
It just said 60.
If the bare minimum urine that we are supposed to produce in an hour is 30 mLs, the most is 50 mLs, and your NCLEX style question asks you, what is the bare minimum urinary output should a nurse expect in an 8-hour period? That will be me multiplying 30 mLs by 8.
That's 240 ml.
That's the bare minimum amount of urinary output that we should actually see in an 8-hour period. In a 1-hour period, we know we want to see a minimum of 30 mLs. Do people urinate every hour? No, not often. Most people, you know, it may take you 2, 3, 4 hours, but even if it takes you 4 hours, I know I expect to see 120 mLs of urine when you do actually urinate. Okay. And dehydration can result in organ failure. If you hypovolemic, you know, you don't have enough blood circulating through your body, which means that different organs will be deprived of the appropriate amount of oxygen that it actually needs. It can result in organ failure. And diagnosis, it talks about how to diagnose dehydration. There are lab tests that can occur where we will check a patient BUN. And the BUN is the blood urea nitrogen. And one of the things you always want to remember with BUN when y'all sitting for your state board and the BUN pop up, if the BUN is high, that patient is dry. So when the BUN is high, you are dry. So if a patient BUN comes back elevated, you know that patient is dehydrated. And if a patient BUN come back low, you know the patient is experiencing the opposite of dehydration. So what would the patient be experiencing if the patient BUN comes back low?
Hypervolemic.
Hypovolemia, and that's correct. The hypervolemia is also called fluid excess or fluid overload, where you have too much fluid in your intravascular space. With patients who are dehydrated, we know they will be high and dry. Their BUN will be elevated. The hematocrit will be elevated. Other levels will be elevated too, because it's like to just say how am I gonna say it? If I poured sugar in a cup and added water, stirred that sugar up, that type of thing, where it's evenly distributed. But if somehow I'm kind of draining the sugar, draining the water where the sugar is remaining, that sugar level will increase. It will increase where it's a decrease in water. So typically, patients who experience dehydration for whatever reason, where they are losing water, they're losing the water from their body, everything else is remaining there. So now it's appearing to be higher than what it actually is with dehydration. With fluid overload, if I actually pour 1 cup of water, mix some sugar or whatever, and the more water I put in there, it's kind of like fluid overload, where the cup is not going to even be as sweet. The water is not even going to be as sweet the more water I put in there. So with fluid overload, a lot of lab levels will come back low. It will come back low because I cannot really, it's just you have too much fluid in your body. It's too much fluid.
Is that when like you press down on someone's like arm or leg and then it's like on a soft?
It's soft, or are you talking about where a patient have swelling? Are you
It
referring?
almost like appears as well. Well, I think it's like a swelling, but it's like I remember talking about it.
And you say you press down and you see your fingerprints or something?
Yeah, like you will
So
see
that would be edema. Your patients who are in fluid overload, you might recognize swelling, but patients who have edema, if it's like pitting edema, and edema is another word for swelling, you may actually take your fingers and press into it just to see if it's pitting edema, and it would be considered pitting edema if you press into that area and your fingerprints are there. And then to kind of determine the degree of pitting edema, you looking at how long do it take for the skin to recoil, for the skin to actually go back to its actual form. And typically a patient who is on who's dehydrated, those fluids will need to be replaced. We want to encourage fluids. Physician may order IV therapy for the patient, where the patient will receive isotonic fluids. And we know those isotonic fluids is normal saline and 0.9. And again, with the normal saline, it's equivalent to the body's blood or whatever. With normal saline is typically something we use for cleaning anything. If we got to flush something, we're going to use normal saline. If we got to clean something, we're going to use normal saline. And it talks about weight is the most reliable indicator of fluid gain or loss. So patients who are dehydrated, physician may order daily weight, those types of things. And just the question, what is the intervention for a patient who is at risk for dehydration? A nursing intervention. Huh? Yeah. Yep, literally to offer fluids would be an appropriate intervention for a patient who's experiencing dehydration. And it talks about fluid excess. And fluid excess is another term for, or terms for fluid excess would be fluid overload, or fluid overload, or hypervolemia. And with fluid overload, and even with dehydration, a person who's more so dehydrated, when they urine, what color urine do you expect to actually see?
Like brown.
Yeah, I'm expecting to see that darker color urine, that amber color urine. A patient who is in fluid overload, what color urine do you expect to see?
Clear.
Be like, yep.
You're going to see that clear. Every fluid overload and fluid volume deficit is kind of, the things are the opposite. So it's like the things are the opposite. So fluid deficit, I'm expecting to see more so concentrated urine, that amber looking color urine, where fluid overload, because you have so much fluid in your intravascular system, this fluid is coming out more so clear or diluted, that pale looking color. So would your BUN be elevated or low with fluid volume excess?
Low.
It would be low, because if your BUN is high, I know you are dry. You high, you dry. Okay. So urinary output would increase with fluid volume overload. With fluid volume overload, one of the things y'all want to know about sodium, salt, those types of things, is that when you put salt in your body, when you put sodium in your body, fluid will stick to your body. So it's a quote, wherever sodium go, water will follow. So you put sodium in your body, that sodium sticking, that water sticking. If you lower your sodium levels, you are getting rid of excess water. So like people who like working on, hey, I want to lose weight, to decrease your sodium intake will contribute to weight loss. It'll contribute to you not, your body not holding on to those fluids. So a patient who is experiencing hypervolemia, the physician may put some restrictions on a sodium intake, and may actually put restrictions on a sodium intake if that's a contributing factor. Would you press mute? And it talks about signs and symptoms of fluid overload, which we talked about them. As for the edema, which would be swelling, most of the time is present in the feet and the legs from fluid overload. You can actually expect your patient to have a bounding pulse, an elevated blood pressure, who is actually experiencing fluid overload. Will somebody read complications? Will somebody read complications?
Acute fluid access typically results in congestive heart failure. As the fluid builds up in the heart is not able to properly function as a pump. The fluid then backs up in the lungs, causing a condition known as pulmonary edema. Other major organs of the body cannot receive adequate oxygen. Organ failure can lead to death.
Okay. And it talks about the diagnostic test again. The diagnostic test will show the opposite of fluid volume deficit, where the diagnostic test is showing that the patient BUN is low, hematocrit is low. It also points out urine-specific gravity under the diagnostic test, urine-specific gravity. That will be urine-specific gravity and BUN kind of go hand in hand, those types of things. So with urine-specific gravity, if it's low, you have too much fluid. If urine-specific gravity is high, then you are high and dry. And your patient who is in fluid volume overload, they can experience difficulty with breathing. They can experience difficulty with breathing because it's so much fluid in an intravascular space where that fluid may even bag up in their lungs, and it will contribute to difficulty with breathing, and even inadequate tissue perfusion where, hey, because you have so much fluid in your body and it's like your blood is diluted, you don't have enough oxygen going to all those different organs. Okay, and it can actually affect your breathing. Your patients who are experiencing difficulty with breathing, one of the best positions for them is to put them in Fowler's position, elevate the head of their bed. Or some patients do well in orthopnic position where they're sitting on the side of their bed and they typically lean over the bedside table to kind of help open their airway so they can breathe better. And it talks about the treatment for fluid volume excess. The treatment for fluid volume excess is to actually get a patient a diuretic. We want to get a patient a diuretic. We know the diuretics causes the patient to urinate a lot because it's ridding the body of excess fluids, excess water. So we definitely want to get a patient a diuretic, and typically the diuretic of choice would be furosemide. It's also called Lasix. That would be the diuretic that we actually give a patient. And it's also the thing that you need to know about a diuretic. Diuretic is a diuretic is considered, it comes from the class of drugs of loop diuretics. They come from the class of drugs of loop diuretics. Every drug have a class that it comes from, where it's multiple drugs from one particular class or whatever. So furosemide is one of the drugs from the class of drug, which is loop diuretics. With loop diuretics, if a patient is receiving any loop diuretics, what the nurse have to be mindful for is that this particular drug will cause the patients to lose potassium. It will cause the patient to lose potassium. So you need to monitor that patient potassium levels. You want to monitor their potassium levels because potassium is critical to the body. Your potassium go too high, your potassium go too low, you are at risk for death. So patients who are on Lasix, we want to monitor their potassium levels. And who are some patients that you all know that requires fluid restrictions?
A person who fluid restriction. Oh, hemodialysis patient.
Yeah, patients who experiencing kidney failure requires fluid restrictions. We know the patient who is in fluid volume excess requires fluid restrictions. And some patients with heart failure is placed on fluid restrictions as well. And again, when you think about the dietary orders, physician probably will order for this patient to be restricted from sodium. Patient who's in fluid volume overload, physician may have sodium restrictions because again, sodium helps it causes the body to retain fluid. And with the different lung sounds, if a patient, you suspect that a patient is in fluid overload, what lung sounds do you think that you will actually hear when you listen into the patient lungs?
Crackles.
You will hear crackles. Yep, you will hear crackles, and that's a sign that there's fluid in that patient lungs. And it just tell you right here under patient education, because it's also important if patients are being discharged and they on a diuretic to make sure that they are educated. If a potassium wasting diuretic is prescribed, teach the patient to eat foods that are high in potassium. So your patient is on Lasix, we know it's a possibility, or it's not a possibility that Lasix will cause potassium loss. One, as a nurse, I know I need to monitor that patient potassium level, but we also need to encourage that patient to eat potassium-rich foods. You need to eat foods that are rich in potassium. And if it comes to a point where the patient dietary intake is not benefiting the patient's potassium level, physician may actually get an order for potassium pills, or they can get potassium supplements. And it's talking about electrolyte imbalance, and this is just pointing out this box is pointing out different foods that are high in sodium. So you want to be mindful as a future nurse, and definitely once y'all hit fundamentals of nursing too, and you covered nutrition and fundamentals of nursing, that was the realization that you have to learn what's in foods. You have to learn what foods are high in fat. You have to learn what foods are high in calories, what foods supply high amounts of protein, sodium, potassium, calcium, because you will deal with multiple patients. You're dealing with a patient with bone issues. You have to know about calcium, how much calcium this patient should be taking, or what foods are high in calcium that this patient can consume. And with your patients who are in fluid overload, our concern is sodium intake. We don't want you consuming too much food that are high in sodium, because it's going to cause you to continue to retain fluids. So it's important to know what's in different foods. And it's important, like now when you all go to markets, start looking at the back of them foods. When I was in nursing school and I took a nutrition class, the nutrition class really taught me how to lose weight. Where at that time, I felt like by reading what I had to read in that course about nutrition, it was the 15-week course, that was like a time where I maintained the body that I actually wanted, because that class taught me exactly how to do it. And then even when I was in nutrition class, I ended up switching my milk, because I was pretty much raised up on a red top milk, where that milk is extremely high in fat. It's high in fat, it's high in calories. When I took the nutrition course, that nutrition course taught me, you need to switch your milk to the pink top milk, because it's less calories. It's not, I think it's no fat in a pink top milk. And as human beings, we should only consume a very small amount of fat. We should only be consuming a very small amount of sodium. A lot of foods that we eat naturally have sodium in it. Meats have sodium in it. Fruits, vegetables have natural sodium in it. But for some of the foods that we eat, it's like it's not enough sodium. I need more salt. But we have to cut down on the salt, because it contributes to different preventable diseases. A lot of us end up with preventable diseases because of diet, because of our diet, where I'm hypertensive, where diet is a contributing factor. I have cardiovascular disease because my diet is a contributing factor. Diet is a contributing factor for a lot of diseases. And it also points out foods that are high in potassium. You want to familiarize yourself with foods that are high in potassium. And will somebody read these two paragraphs under electrolyte imbalance?
At times, a patient may experience problems because of too much or too little of an electrolyte.
Is this in your way?
couldn't see it. Okay.
It's in your
In
order.
general, if a patient experiences a deficient of an electrolyte, the electrolyte is placed either orally or intravenously. If the patient experiences an excess of an electrolyte, treatment focuses on getting rid of the excess, often via the kidneys. The underlying cause of the imbalance must also be treated. The most important aspects of nursing care are preventing and assessing electrolyte imbalances. You must be vigilant and watching for signs of imbalance in high-risk patients. Serum electrolytes are measured on a regular basis. As a general rule, patients should be checked for electrolyte imbalance when there is a change in their mental status, either increased irritability or decreased responsiveness, or when muscle function changes. Patient education is another important nursing role.
Okay. What I want you all to start doing, you all need to at least have like a blank, I would say keep like a separate sheet of paper for labs. As we are going over different labs, you all have to remember those values and you will be tested on them values. And y'all test questions will not really be just the memorization question where, hey, what's the normal sodium value? 135 to 145, 122. No, those are memorization. It's more so patient sodium value is 155. Physician is anticipating that this patient is dehydrated or whatever, where it will be more application questions. So you all need to make sure y'all know the normal values for these different electrolytes, where it's telling you sodium, the normal value for sodium is 135 to 145. You need to memorize that the normal value for sodium is 135 to 145. When it relates to sodium, if your sodium is considered low, that is considered hyponatremia. Sodium that is low is considered hyponatremia. Sodium that is considered high is considered hypernatremia. And for patients who have low sodium, physician can't order additional sodium via IV. Physician may actually order normal saline via IV to actually increase the patient fluid volume. Because again, if you have a lot of sodium in your body, then that's contributing to you retaining fluids. If you have low sodium in your body, you really don't have no fluids in your body, so you'll probably need IV therapy. Okay. And a patient with who is experiencing hyponatremia, they will show signs of dehydration. They will show signs of dehydration because with dehydration, and it's kind of funny because with the sodium is a little tricky because with dehydration, your sodium levels can be low in some instances, and in some instances with dehydration, your sodium level can actually be high. So it's kind of real iffy. So the sodium level is not a huge predictor of dehydration. And it just talks about things that place individuals at high risk for hyponatremia, patients who are NPO, meaning they cannot have nothing by mouth, your patients who's sweating, your patients who are on diuretics. Those are some of the things that places patients at risk for hyponatremia. And your patient who is NPO, what is important as it relates to their dietary needs? Well, what are some safety issues? What are some safety issues you can think of with a patient who is NPO?
Like mouth drying out, maybe?
Yep, their mouth may dry out. So we want to make sure that they are receiving oral hygiene, that you educate your CNA that the patient requires oral hygiene. Make sure you are brushing your patient's teeth. Make sure you are putting Vaseline on your patient lips. But also,
the two, like whatever, like the way they are getting fed, like whether it's internal feeding or whatever, like you gotta like inspect that, right?
when they NPO. Yeah, if they, because every patient who is NPO is not receiving enteral or parenteral feedings. Some patients who are NPO, you could have just cut your arm, where doctor know you about to have a surgery, so we will make you NPO. You about to be NPO for some hours because you're about to have surgery, and with surgery, with positioning patients different way, patients can be at risk for aspiration. But patients who are NPO, you all need to make sure when you get your jobs as nurses that y'all CNAs are not leaving water at their bedside. That's a safety issue. You are NPO, you should not have any fluids at your bedside. So that's something you all need to be vigilant about as future nurses. Your patients who are NPO or your patients who are on dietary changes due to where they need a different consistency of liquid, they need thickened liquids, you want to make sure they don't have regular water at their bedside. So it's just certain things you want to be mindful for as future nurses. And it talks about potassium imbalances. You all need to make sure you know that the normal potassium range is 3.5 to 5. And for any range, anything that's over or under that range is considered abnormal. A potassium level of 5.03, if that was such a thing, that would be abnormal. Potassium level of 5.1 is abnormal. Potassium level of 3.49 is abnormal. It needs to be reported to the physician. Anytime that you recognize anything abnormal with a patient as a nurse, some situations you need to intervene immediately, and some situations require you to report it to the physician. So you all be clear. CNAs are eyes for the nurse. So CNAs are eyes for the nurse. As nurses, we are eyes for the physician. So the normal potassium range is 3.5 to 5 per y'all book. Some facilities y'all will learn the normal ranges can be just a little bit different from y'all book. And I actually placed hypernatremia, but be clear, hypernatremia, they're the opposite of each other. So what you expect to see in hyponatremia, you expect to see the opposite in hypernatremia. With potassium imbalances, if your potassium is low, it is considered hypokalemia. This word right here, hypokalemia. If your potassium value is elevated, what would that be considered?
Hyperkalemia.
Hyperkalemia, and that would be anything over 5. And the biggest concern with potassium is the effect that it has on muscles, the effect that it actually has on the cardiac muscle. That's one of the biggest concerns, because potassium could actually stop your heart, whether it's given in high levels or whether your potassium is low. Individuals who get the death penalty, where they get in the lethal shot, they put in a lot of potassium in there, and that's to stop the heart. But they put a couple other things in their injection as well, but they give them a lot of potassium, and that's partly to stop their heart. And potassium burn. I've given a lot of patients potassium via IV. It definitely burns, and the patient holler about the potassium. What are some things that can cause potassium loss? What are some things you all know that can cause potassium loss? Because I know y'all should have learned one thing today that causes potassium loss.
A lot of sodium.
Sodium do cause, no, sodium don't cause. Well, sometimes sodium and potassium can kind of work in opposites, but one of the things I can tell you about potassium, if you have high sodium levels where you are hypernatremic, to actually consume potassium will push that salt out. It will push that sodium out. So it's good if you are experiencing hypernatremia to actually eat things high in potassium to help rid that sodium. But some of the things that I know that contributes to potassium loss or hypokalemia, we just talked about loop diuretics. So if your patient is on a loop diuretic, we know for a fact that will contribute to potassium loss. Your patient is vomiting, your patient is losing electrolytes. That will contribute to potassium loss. Your patient have diarrhea, that causes your patients to lose electrolytes. That will contribute to potassium loss. And even some surgeries can contribute to potassium loss as well. Sometimes when patients have low potassium, they kind of complain of, oh, I'm having muscle cramps. I'm having these little Charlie horses. Those types of things can be a sign of potassium loss. And the way to actually test to see your potassium levels and any electrolyte level, the physician will do a blood test. And the physician would do you will actually get a blood test to actually test for the different electrolyte levels. And IV can be given, not IV, potassium can be given orally, where we're giving them pills, because even patients who are at risk for hyponatremia or who are on loop diuretics, we can get them encourage them about over-the-counter pills. And again, potassium can be given by IV. And it talks about hyperkalemia. And hyperkalemia is an elevated potassium level. And will somebody actually read this first paragraph? You can stop at excrete potassium.
Hyperkalemia may result from an actual increase in the amount of total body potassium or from the movement of intracellular potassium into the blood. Overuse of potassium-based substitutes or excessive intake of oral or IV potassium. Patient, oh my God. Can you zoom? See, I can't even see this screen.
Because I'm trying to figure out what.
Click the those three dots up there where it's by the X. It should give you the option to zoom.
Let me see if that helps.
You hit the negative, hit the plus.
Oh, to make the words bigger.
Yes.
Okay, I was trying to
There we
make
go.
the screen kind of fuller.
Considering you sharing from the book, I don't think it's gonna do that. I think we tried to do that before.
I
Yeah,
did it
click off
before. I
that.
just can't remember what I did.
This right there, that little arrow that's next to the 6.
Oh
No.
yeah,
Where the 6 at?
where
Right here.
right
Oh,
there.
this.
Yeah. Hit it again. Oh no, just hit the three dots. Hit those three dots.
Yeah,
The tab.
yeah.
Y'all trying to mess stuff up. Well, it's still kind of, it's over here. I'm trying to figure out how to get it to fit to the screen. I'm gonna probably try to work on it later.
Oh, that's how it is. It would, even when like I go in the book and read it, it should be like a little tab at the bottom to go over, but it don't ever really be popping up.
Okay. Well, thank y'all.
You're welcome. Where was it? I can still read it though. Where was it at? I don't think we're on the same part.
Let me see. Pathophysiology and etiology. Okay. Can you see better?
Mm-hmm.
Okay.
But I don't think this didn't stop at the last one. Stopped at potassium.
Oh,
Wait,
it was hyperkalemia. I'm sorry.
Okay. Hyperkalemia may result from an actual increase in the amount of total body potassium or from the movement of intracellular potassium into the blood. Overuse of potassium-based salt substitutes or excessive intake of oral or IV potassium supplements can cause hyperkalemia. Use of potassium-sparing diuretics like aldactone or spironolactone may also contribute to hyperkalemia. Patients with kidney failure are at risk for hyperkalemia because the kidneys cannot excrete potassium.
You all will hear things such as potassium sparing. And when you do hear potassium sparing diuretics, that means that this particular diuretic causes the body to retain potassium. It causes the body to hold on to potassium. So you have potassium sparing diuretics and you have potassium wasting diuretics. Will Lasix be a potassium sparing diuretic or a potassium wasting diuretic?
Wasting?
It would be a potassium wasting diuretic because we know that Lasix causes us to lose potassium. Aldactone is a medication that causes us to retain potassium. It's a potassium sparing diuretic where it spares the potassium is going to stay in your body. So it's just important if patients are experiencing hyperkalemia and we're able to say, hey, the cause of this is that you are on a potassium sparing diuretic, which is causing you to retain potassium. And we know you were on Lasix at first and you were taking over-the-counter potassium. You need to stop the over-the-counter potassium. And even we have to question the patient about their diet. Hey, excuse me. We're questioning the patient about their diet. We want to know what that patient is actually eating. Are you eating foods high in potassium? Because if so, it may come to a point that you need to limit your potassium intake. So with any with any electrolyte, if we are viewing lab results and we see that, hey, this electrolyte is elevated, our patients don't need to consume nothing that has that electrolyte in it. Well, I'm not gonna say nothing, but they don't need to consume it in excess. You don't need a lot of that. Your calcium level is already high. You take an over-the-counter calcium antacids when you already have high calcium. No, you don't need to take that. Your patient have high sodium, they take an over-the-counter sodium antacids, for their GERD, their gastric reflux. And it's like, no, you shouldn't be taking antacids that's high in sodium when you already have high sodium levels. Okay. And it talks about calcium imbalance. And we know calcium definitely have an impact on the musculoskeletal system, more so the skeletal system. It tells you that the normal range for potassium is 9 to 11. 9 to 11 is considered the normal range. Why am I saying potassium? Excuse me, for calcium. The normal range for calcium is 9 to 11. It's talking about hypocalcemia. Hypocalcemia contributes to osteoporosis. And osteoporosis is more so the where the bones are losing it's losing calcium and it's causing the bones to be brittle. And it's easy for the bones to actually fracture. A time I had to do CPR on a patient, I initiated CPR because one of the things when you do CPR as a nurse, you will learn that you can break the patient ribs. And I felt like I've worked with nurses who kind of get a kick out of breaking ribs. But I had to initiate CPR on a patient and she was an older Caucasian woman. And once I got the pressing in her chest, I literally felt her bones just crumbling up. And it was like a different type. But some people got real strong bones where you press it in their chest and you still break their bones. But her bones crumbled up. It felt like a hard piece of bread just crumbling up. And I was like, it was like a shock for me, like, oh my gosh, do I keep going or don't I? Should I stop? But of course I kept going. And the more I was going, everything was just crumbling up. It was just crumbling up. And in my head, while I was doing CPR, I'm like, oh no, she got to have a bad dose of osteoporosis because she was not my patient. she was another nurse patient, but the nurse was off the floor. And I found the patient responsive where she wasn't breathing and didn't have a pulse, and initiated CPR on a patient. But yeah, with osteoporosis, your bones become brittle, and it's easy for your bones to break. I know before my grandma passed, one of my concerns with her used to be like in the wintertime, like, child, that wind better not blow my grandma over, you know, those types of things. And she breaks something. Because for us, if we take a fall, the average person on a Zoom link, we take a fall, we kind of bounce back up. Next day, we might say leg a little so. Grandma, granddaddy take a fall, you know, they may not bounce back up. They may not bounce back up. It's time to take them to the hospital. So hypocalcemia can result in osteoporosis. Patients who are more so at risk for osteoporosis will be the patients who have smaller bones. And when I think about some of the cultures, some of the races of people who have smaller bones, I'm thinking about them Asians, those Koreans. The books say Caucasian Americans, but which they still have small bones, but I just think the look to Americans is kind of changing. It's kind of changing. But patients who are experiencing hypocalcemia, what are some interventions for that patient? What are some interventions, or what are some things that you actually expect the physician to order?
Maybe some calcium pills or something.
Right, we want to give you some calcium. And as a nurse, hey, you need to increase your calcium intake. Make sure that you are consuming foods and with vitamin D, because vitamin D is also needed to absorb calcium in the body, in which all of us naturally get vitamin D from being out in the sun. So that's one of the benefits of the sun, is that the sun helps us synthesize vitamin D. But it's important to know we should not be in the sun between the hours of 11 a.m. and 4 p.m. because of the fact, what is this BRB stuff?
Be right back. They told us to just put it in the chat, like if we have to go to the bathroom or something.
Okay. So patients, where did I just lose myself at? No, so it's actually important for us to be in the sun throughout the day to help synthesize vitamin D, but we shouldn't be in the sun between 11 a.m. and 4 p.m. for long periods of times, because the ultraviolet ray is so strong that it actually contributes to cancer. And I think that's a contributing factor why Caucasian Americans tend to get cancer a lot, because they like to be in the sun. They want to go to the beach, that type of thing. You ain't putting on your sunscreen, you ain't wearing them big hats. It places you at risk for cancer. So a patient with hypocalcemia, we do want them to increase their dietary intake. They may need to take supplements for it. And it actually talks about, with hypocalcemia, there are 2 tests that indicates hypocalcemia. You all should have covered this in Fundamentals in Nursing 2, and that is the Chvostek test and a Trouser test. And a Trouser test is more so where a blood pressure cuff is placed around a patient's arm. And with the blood pressure cuff, we actually pump it up to a certain level. And the patient hands, you will see tremors. You will see tremors. And that is an indication of hypocalcemia as well as hypomagnesia. But most of the time, NCLEX test on hypocalcemia, that the Chvostek sign, well, which this right here is the Trouser sign, where the blood pressure cuff that's wrapped around a patient's arm, you puff it up, hand go to shaking, sign of hypocalcemia or hypomagnesia. And the Chvostek sign, when I was in school, because I had to kind of relate a lot of words to make sure I memorized this information, is more so like the tapping of the patient's cheek will cause some spasms. You will see some spasms, some spasms in their face, some twitching in their face, those types of things. That would be a Chvostek sign, and it's a sign that the patient is experiencing hypocalcemia. So with the Chvostek sign, I know that start with a C, and the cheek start with a C. So I know if they, NCLEX question was to say, physician is tapping it on patient cheek. What is the patient, or what is this test called? I'm gonna kind of think of that C for cheek for Chvostek sign. And it also gives you all a list of foods that are high in calcium. So you do want to make sure that you know the foods that are more so high in calcium. And it talks about hypercalcemia. Hypercalcemia, you definitely have a lot of calcium in the blood. You have a lot of calcium in the blood. Hypercalcemia can result from different diseases. Hypercalcemia can result from consuming too much vitamin D or consuming too much calcium. Hypercalcemia, having a lot of calcium in your system also can cause kidney stones. It can actually cause kidney stones, but these particular kidney stones, because kidney stones can be caused by different things. High sodium intake can contribute to kidney stones. High calcium intake can contribute to kidney stones. And with them kidney stones, you know, your patient have to, they typically, when they urinating them out. And some of them stones are bigger than others. So with kidney stones, you can kind of imagine pushing out a little rock out your pee hole. That might actually tear some tissue where you might actually bleed too. So bleeding is common with kidney stones. Okay. And with a patient who is experiencing hypercalcemia, physician may actually put them on some type of restrictions with calcium, and physician may give the patient some type of diuretic, to actually increase urination, so the patient can actually lose the calcium through urination. When it talks about magnesium imbalances, magnesium definitely have an impact on our reflexes or whatever. It points out, where are we at? Magnesium, the normal range for magnesium is 1.5 to 2.5. 1.5 to 2.5. So the magnesium levels kind of affect our reflexes. And that's the important thing to know. And when magnesium is low, you know, the important thing for any low electrolyte is to replace it. The whole goal is to replace electrolytes when they're low. When the electrolytes are high, the goal is to administer fluid with some type of diuretic to actually help rid the body of that electrolyte. Okay. So next is talking about acid-base imbalance. So I actually want to discuss something with you all about acid-base imbalance. Acid-base imbalance. What do your book tell you the normal pH is? What is the normal pH?
7.35
7.35
to
till
7.45.
that's the normal pH. What is the normal bicarbs?
22 to 27.
bicarbs slash is also called HCO3. Do y'all book say 22 to 26 or 22 to 28?
22 to 26.
22 to 26 is the normal bicarb range. Also, the normal carbon dioxide. What is the normal CO2? What is the normal CO2?
40 to 40.
45 to 35.
35 to 45.
Mhm.
Yeah. So typically in the human body, our acid-base imbalance can be respiratory. I mean, it can affect the respiratory system. And it acid-base can affect metabolism, the metabolic system. So acid-base imbalance can be respiratory in nature or metabolic in nature. When the body pH, it actually represents whether the body is acidosis or acidotic. Or whether the body is experiencing alkalosis. A pH that is less than 7.35 is an indication of acidosis. A pH that is greater than 7.45 is considered alkalosis. However, the normal range for the body pH is 7.35 to 7.45, and that is considered neutral, where everything is neutral. But below 7.35, patient is experiencing acidosis. Above 7.45, patient is experiencing alkalosis. Bicarbs, typically, if you have a lot of acid in your body, bicarbs are buffers. They can be, the body have a mechanism where it kind of signals the kidneys to secrete the bicarbs. And the bicarbs actually work to try to lower acid levels. If acid is a little bit too high, those bicarbs are working to try to actually lower it. Okay. When a patient has elevated bicarbs, that is a sign of alkalosis. Patient have low bicarbs, that is a sign of acidosis. Now with CO2, we know that is more so acid. If the CO2 is elevated, would that be a sign of acidosis or alkalosis?
Alkalosis.
So if I just told you
Acidosis.
it's acidosis. I just told you that the CO2 is an acid. So if we have high acids, meaning over 45, we definitely know we got a lot of acid. But if the CO2 is low, patient is more so alkaline. And these are lab values that you will actually get about your patient, and where you want to differentiate when your patient is experiencing some type of respiratory imbalance or a metabolic imbalance. Is your patient experiencing a respiratory imbalance or a metabolic imbalance? These ranges for pH, HCO3, and CO2, you all need to memorize it. You need to make sure that you know the normal ranges for each of these lab values. So how patient results will actually present, you will see patient results come in where it's saying pH is 7.47, HCO3 might be 27, CO2 is 34. when you receive lab values like this, because what occurs, you have to be able to look at lab values and differentiate whether this patient is experiencing metabolic acidosis, metabolic alkalosis, respiratory acidosis, or respiratory alkalosis. That's what you want to differentiate. So there are four main acid-base imbalances. And the way that you actually figure it out is first, you look at the pH. The pH is going to let you know if it's an acid, if the patient is in acidosis or alkalosis. So looking at the pH, is this patient experiencing acidosis or alkalosis?
Alkalosis.
Patient is experiencing alkalosis. Now, whenever the bicarbs are out of range, you want to think of metabolic issue. If the CO2 is out of range, think respiratory issue. And CO2, we know CO2 is an acid. It's produced in multiple areas. Our body cells can release CO2. Most of the time, if our metabolic cells are releasing CO2, it could be because of due to starvation. That can cause our cells to actually release CO2. We know we have a lot of acid in our stomach. That acid that's in our stomach, it actually works as a defense mechanism, because as we eat in germs and we swallow in germs, some of those germs are killed by the acid in our stomach. Because of course, there are germs all over different foods we eat. You go to the market, you like to eat your apple, your strawberry, all types of germs on there. So we eating germs. Other than the fact that we just can't see the germs we eating, but we definitely eating them. But again, with your patient and also with the CO2, you know, when we actually are breathing, we expiring or exhaling, we are exhaling CO2. CO2 is a body waste. It's waste. So we're exhaling CO2. When we breathe in, we're breathing in oxygen for gas exchange. When we expire, we exhale. We are expiring CO2. So what I was pointing at, when looking at different lab values, first thing you want to look at is the pH, because it will let you know whether the patient is experiencing alkalosis or acidosis. With the bicarbs, typically if I look at a bicarb, if that bicarb is out of range, I'm going to think a metabolic issue. If the carbon dioxide levels is out of range, I'm going to think a respiratory issue. So we're looking at these two, which one is out of range, the bicarbs or the carbon dioxide?
The bicarb.
So which out the four, what is this patient experiencing?
Alkalosis.
No, it's called something more than that. Out the four, what is the patient experiencing?
Respiratory alkalosis.
It wouldn't be respiratory alkalosis, because the
Metabolic.
CO2 is not out of range. I want you to make sure you're clear, because you said respiratory initially. So I want you to understand why it's metabolic. Or explain to me, or somebody explain why it's a metabolic issue.
It's a metabolic issue because the bicarbs are off, they're high.
Yes. The first thing we're looking at is the pH to decide whether it's acidosis or alkalosis. After the pH, we need to look at the bicarbs and the CO2 to determine which one is out of range. And if one is out of range, then that's the issue it is. And it tell you if bicarbs, if out of range, think metabolic issue. Bicarbs is out of range, So between 1, 2, and 3, and 4, what acid-base imbalance is this patient experiencing? This patient is experiencing metabolic alkalosis. You all can type your answer in for this problem in the chat once I'm finished. So you can type your answer to that one in the chat, and I'm gonna do one more. So we're gonna label this number 1. CO2. So 2 problems to write your answer in a Zoom. So you'll write number 2, whether it's 1, 2, 3, or 4. You'll write number 3, whether it's 1, 2, 3, or 4, whether it's metabolic acidosis, metabolic alkalosis, respiratory acidosis, or respiratory alkalosis. Cody Allison, what is number 2? Cody.
Yeah, it's respiratory acidosis.
Number 2. Okay. Who else I didn't see in this box? And do you all agree that it's number 2 is respiratory acidosis?
Yes.
Yes.
Oh, okay. I had it for sure, but I don't know why I still had it backwards. But I get it now. I just had it.
Yeah, because when I look at number 2,
For number 3, what does that pH say? I can't really make it out.
7.33.
Thank you.
What is number 3?
Me still?
Yep, that's fine. Yeah,
Res- respiratory acidosis again?
correct. No, it's not. It's not. No.
Respiratory alkalosis.
Mm-mm.
Metabolic acidosis?
Why is it metabolic acidosis?
Well, I know it's acidosis,
Mm-hmm.
but
Alkalosis, metabolic alkalosis.
It is acidosis.
Okay.
7.35 to 7.45 is normal range. Anything below 7.35 is considered acidosis. Anything greater than 7.45 is considered alkalosis. So is the 7.33 a representation of acidosis or alkalosis?
Acidosis.
And then the next thing you need to ask yourself is which one. So which of these values are out of range? So if the HCO3 is out of range, is that considered a metabolic issue or a respiratory issue?
Metabolic.
Metabolic. And when a CO2 is out of range, is it considered a metabolic issue or a respiratory issue?
Respiratory.
Respiratory.
Which one is out of range?
CO2.
No,
No,
the
I'm sorry.
CO2
I'm
is
sorry.
within normal limits.
Bicarb.
The CO2 is within normal limits because it's 35 to 45. The bicarbs is not within normal limits. The normal range for bicarbs is 22 to 26. Well, we know this is way below 22. So the bicarbs are out of range. Anytime the bicarbs are out of range, I know off rip it's a metabolic issue. Now, if I switch this around, that'll turn it into respiratory acidosis, because now the CO2 is out of range, where the bicarbs are within normal limits. Okay, so I encourage you all to take a test, not a test, to take a picture of this because you all will be tested on it.
Mr. Williams, can you send it to us because the pictures look small.
Kiara Hicks, you can't zoom in. Did you just smack your lips?
No.
Okay, I'm gonna actually I may post this Zoom meeting to Canvas. Let me see. So it's also important to know as it relates to acid-base imbalances is that different things can cause different acid-base imbalances. And it just points out the things that can contribute to acidosis. What are the different things that can contribute to having too much acid in your body or not having enough base in your body? The base is the bicarbs. And it talks about the things that contribute to you not having enough acid in your body and what contributes to you having too much base in your body. And too much base is what causes alkalosis. Your patient, so to be clear, to think about our respiratory system, we are breathing. When we are breathing, we're breathing in oxygen. When we blowing out, we are blowing out CO2. A patient who's not able to expire, what respiratory imbalance are they at risk for? Your patient cannot expire. We know what patients inspire. We know what patients expire. If your patient cannot expire, what acid-base imbalance is they at risk for?
CO2.
Respiratory acidosis?
Respiratory acidosis is correct. And tell me why it would be respiratory acidosis.
Because there's no air going out, it's just coming in. I mean, you're just like, you're not exhaling, I guess.
When you
Come on, give me
breathe in
the-
oxygen, you're supposed to breathe out CO2, so the CO2 will be staying in your body, right?
Oh yeah.
Correct. You're retaining CO2. You are retaining a lot of acid. You're retaining a lot of acid. So that's what's occurring. And to think about the patient who's breathing heavy, your patient is having a panic attack. They just found out their loved one died. They having a panic attack. They hyperventilating. They breathing extra hard. Those types of things. What acid-base imbalance is this patient at risk for?
Respiratory alkalosis.
Respiratory alkalosis. You are blowing off a lot of CO2. And one of the interventions for respiratory alkalosis, when we see that our patient is hyperventilating, hey, grab this brown paper bag, and I want you to do all that heavy breathing in this brown paper bag. That way, what they blowing out, they can suck back in, because you're losing too much CO2 when you're actually hyperventilating. Your patient who is constantly, I'm just sick, I'm just throwing up everywhere. Any little thing I eat, I'm just throwing it up. What acid-base imbalance is this patient at risk for?
Metabolic alkalosis.
I'm at risk for metabolic alkalosis because what I'm throwing up is the acid. That's what I'm throwing up. When I'm throwing up, I'm bringing up the acid that's in my stomach and placing me at risk for metabolic alkalosis. So you all want to make sure you review the causes of these different acid-base imbalances. Make sure you all review the different causes and what treatment will actually be. Okay. Chapter 27 talks about the hematologic and lymphatic system function, assessment, and therapeutic measures. Would someone read this paragraph under normal hematologic and lymphatic system anatomy and physiology in its first sentence under blood?
The hematologic, oh, go ahead, Katrice, if you was gonna read.
I know you've been doing it. The hematologic system includes the bone marrow, blood, and blood components. The lymphatic system includes lymph nodes, nodules, which filters pathogens for destruction, and lymph vessels, which returns lymph to blood. The general function of blood and are transports of substances, regulations of blood temperature, pH and fluid balance, and transport of cells that offers the body protection.
Okay.
You want me to keep going?
No, thank you.
Okay.
So we do talk about some AMP. We talked about the plasma. The plasma is a component of blood where water is the main component of plasma. In blood is several components that are in blood from different blood cells, the white blood cells, platelets, electrolytes, those type of things are in the blood. And it's talking about stem cells, where stem cells are unspecialized cells that give rise to immature red blood cells, white blood cells, and platelets. So stem cells are being researched because they can contribute to blood cell production and platelet production. Okay. And they actually, the stem cells can kind of work as any cell in the body. They tend to replace specialized cells that are damaged or lost. It's kind of like a repair system. The stem cells kind of work as a repair system. And it's talking about the red blood cells. You do need to know the normal range for red blood cells. Hematocrit, you need to know the normal range. Hemoglobin, you need to know the normal range. Okay. And it actually tells you some significance of abnormal findings with red blood cells. We definitely know if a patient is bleeding out, that will contribute to a decrease in blood cells, and it also will contribute to a diagnosis of anemia. Hematocrit, hemoglobin, we do know that it actually can increase in dehydration, those types of things. White blood cells, you need to know the normal range for white blood cells. White blood cells that are elevated can be a sign of infection. Elevated white blood cells is a sign of infection because when we have something foreign in our body or we have an infection in our body, the white blood cells are being secreted. They're being secreted to actually try to fight the infection, but sometimes our white blood cells aren't effective. So we actually need some type of medication to actually fight different infections. When white blood cells are low, it makes me think of maybe there's an issue with the bone marrow where white blood cells are being produced. There's some type of production issue if white blood cells are low. And these different neutrophils, eosinophils, basophils, lymphocytes, monocytes, they are all components of white blood cells. They are components of white blood cells, so they do work to actually help the body fight foreign antigens, whether that foreign antigen is something infectious or whether it's an allergen. Because it tells you eosinophils increase in allergic response, neutrophils increase in infection, lymphocytes increase in infection, those types of things. So they do help to actually attack foreign antigens. And it also points out to you these terms you need to know. Increased white blood cells is called leukocytosis. So a patient who has elevated white blood cells, we will call that leukocytosis. Patients who have decreased white blood cells, it's called leukopenia. A lot of times when you hear penia, penia means something is actually low. And some terms to point out up here to make sure you are clear. Patients who have elevated red blood cells, it will be called pilocythemia. Patients who have decreased red blood cells is called anemia. Anybody who has anemia, anemia is typically secondary to something. Anemia is secondary to something. Hey, because even like younger females, they ain't don't got no stab wounds or nothing like that where they bleeding out and doctor diagnosing them with anemia. Hey, you know, what is the cause of the anemia? What is this secondary to? In some females, anemia can be secondary to the menstrual cycle. You have a heavy blood flow during your menstrual cycle, you're losing a lot of blood. So that's the reason why you are anemic. And platelets, you need to know the normal range, 150,000 to 450,000. Platelets work in our body. So just to say, if I just cut myself right now, with cutting myself, of course, you're bleeding. You want to wash that area and you want to apply pressure. You want to apply pressure to that area to stop the bleeding. The pressure stops the bleeding, but what also occurs is platelets travel to that area and the platelets clot that area off to prevent the bleeding. A clot forms. So that's the need for platelets. Platelets clot. Platelets contribute to clotting. If you have an extreme amount of platelets, you are at risk for blood clots. If you have an awful lot of platelets, you are at risk for blood clots. And we know them blood clots can travel through the body And depending where those blood clots travel, depending on the size of those blood clots, it can cut off circulation. Because the picture with the deep vein thrombosis, a blood clot then traveled and got stuck somewhere in your leg, because typically it's common for blood clots to get stuck in your leg. That would be a deep vein thrombosis, where it's going to cut, it can possibly block all circulation off to your lower leg, or it can block some of the circulation where you're getting some blood but not enough, and you can still experience symptoms. You have a blood clot that lodged in your heart, that's going to block blood flow to your heart, and that can contribute to heart failure. It can contribute to death. Blood clot travel to your brain, that's blocking blood flow to your brain, and that will actually, that's considered a stroke. That's considered a stroke, and that blood clot can even cause death. When your platelets are low, that means that you have no platelets. If you are actually bleeding, ain't too many platelets available to travel to that area. So all you about to do is bleed out. Patients who are who have low platelets, which is considered thrombocytopenia, that patient is at risk for bleeding out. We need to put that patient on bleeding precaution. And bleeding precaution is making sure it's nothing that the patient can bump their body up against, because it will cause the patient to bleed out. And sometimes when patients are when they are experiencing thrombocytosis, which is increased platelets, your patient experiencing thrombocytosis, they can actually bleed out of their ears. They can be bleeding out their eyes, bleeding out of different openings in the body, and which is a sign of thrombocytosis. Patient need to be on bleeding precaution. And for patients who are anemic, and even women who are at menstrual cycle age, I encourage them to increase their iron. A lot of women be, oh, I'm just so cold. Oh, I'm just so cold. Yeah, when they at menstrual cycle age, some of that can, the contributing factors can be the blood loss from the menstrual cycle. So when you know you're about to come on your menstrual cycle, hey, let's up my iron so it can increase blood production. Iron increases blood production. Of course, there are over-the-counter iron supplements. There are foods that are high in iron, some of the organ foods, liver, beets high in iron, raisin high in iron, those type of things. But patients who are receiving iron for red blood cell production, the iron can contribute to constipation. So patients need to be educated that they need to drink more fluids. If they are taking iron supplements to prevent dehydration, patient's stool may change in color. So patient need to be educated about the change in color of their stool, where their stool may actually come out dark. It may look black from iron supplements. Okay. And it points out to you all that red blood cells live for about 120 days. Where am I there? And it also points out the term hemolysis. Hemolysis is the destruction of red blood cells. And different things can contribute to the destruction of red blood cells. Hemolysis tend to occur in the spleen. That's what area that red blood cells are destroyed. Okay. And it talks about white blood cells. Just be clear, white blood cells are used to help fight off infection. Be clear that platelets are blood cells that forms clots to stop bleeding. The lymphatic system, will somebody read this paragraph?
The lymphatic system consists of lymph vessels, lymph nodes, and nodules, the spleen and the thymus. Functions of the lymph system includes the return of tissue fluid to maintain blood volume and protecting the body against pathogens and other foreign materials. Immunity is covered in the Unit 4.
Okay.
You want me to keep going?
No, thank you. And it talks about the lymphatic vessels. And the lymphatic vessels, due to the fact of me here, however, the lymphatic vessels actually carries lymph by the lymph capillaries and return it to the right subclavian vein. Okay, so the lymphatic system is dealing with the actual immune system. It's dealing with the immune system. It points out these different blood types. We all have different blood types. So it's some things that you actually need to know about the different blood types. So with the different blood types, if you have an O blood type, you are considered a universal donor. Individuals who have a O blood type is considered a universal donor. Excuse me. No, sorry. Give me 1 second. So with the different blood types, O is the universal donor, meaning that a person with type O blood can give their blood to an individual who is type A and B. They can give their blood to an individual who is type B, and they can give their blood to the individual who is type A. The individual who has type AB blood is a universal recipient. They can receive blood from any blood type. They can receive blood from type A because they have A and B. They can receive blood from type B because they have B, where they have A and B. And they also can receive blood from blood type O, because blood type O is a universal donor. Type A blood can only receive blood from a type A or from the universal donor. Type B blood, a person with type B, if they require blood, they can only receive blood from an individual who is type B or the universal donor. If a patient receives incompatible blood, that's when hemolysis can occur. Those red blood cells can be destroyed. Patient can have an actual reaction from it. So you want to memorize that information. And it talks about the spleen. The spleen is where red blood cells are recycled, as well as platelets, and white blood cells are actually stored in the spleen. And really, they don't understand the function of the spleen completely or whatever. However, the spleen do help fight off some infections. It can help fight off some infections. It's important to be clear that an individual can live without a spleen. So with an individual living without a spleen, it can actually affect their ability to fight off infections some. Excuse me, I kind of worded my stuff wrong. The spleen do have multiple functions, and those functions are that the spleen can recycle red blood cells, and the spleen actually stores white blood cells and platelets. But individuals do have their spleens removed, which is a splenectomy. And with a splenectomy, you can live without it, but some infections you will be at risk for because the spleen stores white blood cells. And it talks about the thymus. The thymus is in our throat. The thymus typically gets smaller with age. You can live without a thymus. Some people, thymus don't get smaller. It actually keep growing, and it contributes to some diseases. My mom had myasthenia gravis because her thymus would not stop growing. And that's like a rare disease, and mostly African-American women who are like in their late 30s, early 40s, or whatever, where their thymus have to be removed to potentially reverse the signs and symptoms of myasthenia gravis. And just some terms that you want to familiarize yourself with: petechiae, which is small purplish hemorrhage spots under the skin, which can be a sign of bleeding, where your patient is actually bleeding internally. And ecchymosis can be a discoloration from your patient hemorrhaging under the skin, just as well as purpura. And it actually show you the lymphatic system, that we have lymph nodes in several areas of the body, inguinal lymph nodes, axillary lymph nodes, those type of things. And with the different lymph nodes can emerge as a result of infection. It's letting you know your immune system is trying to fight something off. And sometimes when you have lymph nodes in a localized area that are palpable, or that actually can be seen, you probably have a localized infection. If lymph nodes only pop out in your neck, you probably got some type of infection up in there. Lymph nodes popping down by your pubes, you probably have some type of infection. When you have lymph nodes popping up everywhere on your body, you must have some type of systematic infection. Something systemic is going on if those lymph nodes are emerging throughout the entire part of the body. And it just talks about some of the, with the aging adult, the effect that aging has on a hematologic and lymphatic system. And where it's telling you patient immune system is not responding quick enough, which is placing them at risk for infection. With the older population, iron deficiency, where the individual do not have enough iron in their body, and it's contributing to anemia. And patient is at risk for dehydration as a result of reduced plasma volume. And typically in this course, I will not test you all on the gerontology population, pediatrics, or OB, because of the simple fact you all will have that class in the future, or those classes in the future. And it's just giving you some it's giving you all some information on questions you should be asking when you are doing a health history, because there are questions we should be asking newly admitted patients. And one of the things with family history, it's really important to ask about family history, because some diseases run in the family. Some diseases run in the family. If you didn't have mama, auntie, and grandma with breast cancer, chances are high that you may be at risk for it, that you need to start going to be screened for it at a certain age regularly, those types of things. So family history is key, because again, some of the diseases that run in the family just run in the family. It talks about a bone marrow biopsy. What is a bone marrow biopsy?
When the marrow is tested, well, the bone marrow is tested, it's retrieved. No.
Okay, you said when a bone marrow was tested and retrieved. So
no, when you retrieve bone marrow and you test it, or like do cultures on it.
Definitely, they getting some tissue from the bone marrow. So they're using a needle, they're sticking a needle in you to actually get some of the tissue from the bone marrow. Any biopsy, they're sticking a needle in whatever organ that they need the biopsy of to actually get some tissue, to aspirate tissue. What is a biopsy for?
Maybe to rule out possible malignancy cancers.
Yeah,
or other health concerns.
that's correct. Because most people think when they think biopsy, that a biopsy is only for checking for cancer, but a biopsy can be used for multiple things. I mean, to actually diagnose multiple diseases. But the fact of the matter is, it's not routine to just be sticking a needle up in somebody to diagnose them for disease. There's other ways to do it, but some diagnoses do require an actual biopsy. And with a biopsy, due to the fact that a huge needle is penetrating a given area, the nurse needs to monitor that injection site. That would be part of your responsibility as a nurse. When your patient have a biopsy, you want to monitor that injection site to ensure that you don't see heavy drainage. You're not seeing heavy drainage. It's not copious amount of blood coming from that area where it's a sign of hemorrhage, those types of things. So you need to monitor that site. The physician who did the bone marrow aspiration should have put a really tight dressing over that area. And just to say, if a patient had a lung biopsy, you have to monitor that site. What else do you need to monitor?
Their breathing.
I need to monitor your respiratory system, because it's a possibility if they done stuck a huge needle near your lungs, they could have punctured a lung. So I need to monitor your respiratory system. So any area that a huge needle is being stuck in, or even if it's a surgical site, you want to monitor that site. You want to monitor the proximal site. You want to monitor the distal site. Patient had knee surgery. Let me be checking your pedal pulses. Let me check the pulses in your feet to make sure blood is circulating to that area. Okay. Somebody read this paragraph right here, the nurse's role.
The nurse's role in bone marrow biopsy is I can't even see it,
Faceted.
multifaceted. Thank you. You may need to help coordinate between the laboratory and the health care provider, establish a time to do the procedure, and determine who obtains the supplies, such as the disposable bone marrow aspiration tray and specialized needles. Be sure to obtain an order for an analgesic and to administer it before the procedure. Assist with positioning the patient before and during the procedure. Afterward, observe the aspiration site for bleeding and infection. Provide emotional support to the patient before, during, and after the procedure.
Okay, thank you. And it talks about a lymphangiography. Whenever you hear the word graphy, what do that make you think?
Examination of the lymph.
Yeah, some type of examination, some type of it just makes me think
Visual
like
examination. Sorry.
Yeah, some type of equipment like X-ray, that type of thing. Like they're gonna do something like that, where you just breaking the information down to make sure you all understand it. They talk about coagulation studies. What do they mean when they talk about coagulation?
Clotting time.
Clotting factor.
Y'all are correct. Coagulation studies make me think more so about how long do it take for you to clot? Are you clotting in a normal time frame?
It's about 10 to 12 seconds.
For different ones, yeah. So it talks about the thrombin time, which is the normal range for a male and a female. It talks about the INR. You want to remember the INR, excuse me, that with INR, less than 1.3 seconds will be considered normal for a patient who is on warfarin. excuse me, a patient who is on warfarin, the therapeutic range is 2.0 to 3.0. So a patient who is actually on warfarin, we're gonna get them at their therapeutic range for their INR should be 2.0 to 3.0. But all this time is telling you is the amount of time it takes for a patient to clot. So for a patient prothrombin time to be high, that's letting me know it takes you a long time to clot, because these are the seconds it takes for you to clot. It's taking you a long time to clot. You at risk for bleeding out. The patient who prothrombin time is low, as well as the INR, the activated partial thromboplastin time, when they are low, it's making me think that you are at risk for clots. You are at high risk for clots. And again, those clots can shut the body down. Depending on where those clots actually lodge at, it will contribute to tissue death. So you want to remember the normal range for the INR. You want to remember the normal range for the PT as well as the APTT time, okay? And it's talking about blood administration. Typically in Michigan, an RN has to start blood, and then an RN can actually delegate the task as for monitoring the blood administration. It talks about different blood products that can be transfused. So there are different blood products that can be transfused. Most people think of only the red blood cells, but platelets can be transfused if your platelet level is too low. Albumin can be transfused. For some reason, we kind of skip this word, but albumin actually is a protein that works to pull fluids intravascular, to pull fluids in an intravascular space. When your albumin is low, it will result in low fluid volume. So it tells you albumin can cause hypovolemia, is caused by hypoalbuminemia. So low albumin can cause low fluid volume. High albumin actually works to pull fluid into the intravascular space, okay? And it's talking about when blood is being transfused, blood should never transfuse longer than 2 hours. It should not transfuse longer than 2 hours. And you should not leave blood just sitting for over 2 hours. And typically with transfusing blood, the equipment that the blood will be transfused through actually need a filter connected. It need a filter connected so it can kind of filter out any like debris or different things that don't belong, different harmful particles. And it talks about warm blood. It's important that blood is warmed in different situations, because if patients are receiving a lot of blood due to blood loss, if you're giving them that blood at like a cool temperature, hemolysis can actually occur. Patient can have a reaction from that cool blood. So you want to make sure blood is warm or then set pretty much at room temperature. And monitoring, will somebody read monitoring?
Whether or not you actually administer the blood, you will likely participate in monitoring to prevent complications or to detect and treat them quickly if they occur. Stay with the patient for the first 15 minutes of the blood transfusion to assess for any immediate reactions. The 15 minutes begin when the blood enters the vein. If saline solution is in the tubing, it may take several minutes before the blood reaches the patient. Check in, document vital signs before starting the transfusion. After the blood loss begun to infuse, and after the infusion is complete, Always follow institution guidelines for vital sign monitoring during the transfusion. Assess the patient for signs and symptoms of complications.
And when blood is being, when you have an order to administer blood, vital signs should be checked pre, intra, and post. And what do those three terms mean?
Before, during, and after.
Correct. So you want to check vital signs pre, intra, and post. You should be checking vital signs within 15 minutes of that blood running. The vital signs need to be checked, because within the first 15 minutes is where individuals tend to have a reaction to the blood if they're going to have a reaction. It normally occurs in the first 15 minutes. That's why it's critical for somebody to remain with that patient for those first 15 minutes to be vigilant for a change in condition when they're receiving blood. Once the blood has transfused, which will be post-transfusion, patient need vital signs checked again, just so you can compare to make sure nothing has occurred. And you know, vital signs are an indicator of health status. Vital signs is an indicator of health status. And it just talks about complications of blood transfusions. It is a serious procedure that can be life-threatening if errors occurs, and complications can be things such as febrile reactions, hypersensitivities, hemolytic reactions, anaphylaxis, you were allergic to it, circulatory overload, you received too much blood, and even death. Death can result from a blood transfusion. And it talks about febrile reaction. What do they mean, febrile reaction?
When the patient has a fever.
Patient developed a fever from this transfusion. And one of our drugs of choice for a fever would be acetaminophen. We want to get this patient acetaminophen, which is Tylenol. Get them Tylenol to bring down their temperature. No fluid restrictions. We also can offer them fluids, those types of things for febrile reaction. Urticarial reaction is where patient get the breaking out in hives. And in an event that you recognize a patient is having a reaction to a transfusion or any IV therapy or any therapy period, your responsibility is to stop that therapy. You want to stop that therapy. Patient having a transfusion reaction, you need to stop the IV, you need to contact the physician. But even before contacting the physician, you might delegate to your CNA, hey, get a set of vitals on this patient. Those types of things, remain with that patient just so the patient won't decline further. But anytime it's a transfusion reaction, the transfusion needs to be stopped. A hemolytic reaction is considered the deadliest. And that is the cause of incompatible blood, where you received some blood that was incompatible. It causes the blood to start, the body, the immune system, to start breaking down those red blood cells. And again, anytime a patient is experiencing a reaction, stop the IV fusion. It talks about anaphylactic reaction. That's where the throat go to closing. Patient throat is closing up due to some type of allergic reaction. Circulatory overload. What might be a sign to you that the patient is experiencing circulatory overload?
Distended neck veins. They may have crackle or wheezing when we auscultate.
Awesome. Yep. Chapter 28 is talking about nursing care of patients with hematologic and lymphatic disorders. It talks about hematologic disorders. Will somebody read this first paragraph under hematologic disorders? Okay. Will somebody read this paragraph, please?
Patients with hematologic disorders have problems related to their blood. What do you suppose happened when there are too many blood cells or too few, or the cells are defective. When red blood cells are affected, oxygen transport is also affected, causing symptoms related to poor oxygenation. When white blood cells are affected, the patient is unable to effectively fight infection. If platelets or clotting factors are affected, bleeding disorders occur.
So it talks about anemia. Anemia is when a patient has a deficiency of red blood cells or hemoglobin or both. And anemia is always secondary to something. It's always secondary to something. And it talks about the pathophysiology, the way the disease function in the body. Patho mean disease, physiology, function. Individual don't have enough blood cells. And it's something that's causing it, individual to not have enough blood cells. Okay. And it talks about the etiology. And what it points out, vitamin B12 deficiency can result in percunicuous anemia. Actually, will somebody read this paragraph under etiology?
Dietary, okay, go ahead.
Dietary deficiencies, iron, folic acid, and vitamin B12 are all essential to the production of healthy RBCs. A deficiency of any of these nutrients can cause anemia. Pernicious anemia is associated with the lack of intrinsic factor in stomach secretions, which is necessary for absorption of vitamin B12. See nutrition notes for more information.
Okay. It talks about hemolysis. Again, hemolysis is the destruction of red blood cells, which can result in anemia. It's multiple forms of anemia. You do want to familiarize yourself with pernicious anemia, where that type of anemia is caused due to vitamin B12 not being able to be absorbed by the stomach. In patients who have portions of their stomach removed, they are at risk for vitamin B12 deficiency, which will contribute to pernicious anemia. And it talks about the different symptoms of anemia. One of the symptoms of anemia is pallor, where patients starting to look pale. Individual is looking pale. If you don't have enough blood in your intravascular space, that's going to contribute to low blood volume. And typically, when we don't have enough blood in our body compensates for that. And the way our body compensates for that is our heart start beating really fast. And the reason our heart is beating really fast is to try to keep that blood pumping and to get that blood to those major organs, if to all. That's the whole goal of increasing the heart rate when you have low fluid volume, to make sure that tissue perfusion is occurring. But sometimes the heart cannot keep up with the body demands. Okay. It also points out under signs and symptoms, your patient who have pernicious anemia, they typically have an inflamed tongue, which is called glossitis. It can appear beefy red, like a beefy red looking tongue can be a sign of pernicious anemia. And it just gives you a list of clinical manifestations of anemia. We definitely know that pallor is one that actually presents. It talks about mild anemia, where we're looking at the patient hemoglobin level. A hemoglobin between 10 and 14 would be considered mild anemia. Hemoglobin 6 to 10 is considered moderate anemia. Typically, patients who are below 7, most of the physicians order a blood transfusion. If your hemoglobin is below 7, that's where a lot of the physicians end up ordering a blood transfusion. Okay. And it talks about To diagnose anemia, what are some of the values, lab values, would the physician look at to actually diagnose anemia?
The hemoglobin.
Yeah. Some of the lab values to diagnose for anemia.
Would it be like, I don't
Is
want
it the red blood count?
Red blood cells, hemoglobin,
And the hematocrit.
hematocrit. That's what they want to look at to actually diagnose anemia. Okay. And it's actually talking about aplastic anemia. And with aplastic anemia, it's typically almost fatal, and it's more so where body is not able to produce enough red blood cells. So you definitely will probably need a transfusion, or if it's caught early, patient may need to be started on some type of iron supplements to contribute to red blood cell production. Patient bone marrow may need to be factored in if the patient is not producing enough red blood cells. Is there something wrong with the individual's bone marrow? Okay. And it also informs you one of the symptoms of aplastic anemia will be pallor, where you're seeing actual pallor. And this is just a picture of ecchymosis, which is some type of internal bleeding. Patient is bleeding internally. Okay. And it also show you a picture of petechiae, which are those dots. They kind of look like little dots of blood. Patient is bleeding internally. And it just talks about, with therapeutic measures, early identification of the cause of aplastic anemia is important with correcting the underlying problem to figure out why the body is not producing enough red blood cells. So that's the biggest thing, to figure out why isn't the body producing enough RBCs. Okay. And your patient have low white blood cells. What do you actually anticipate to occur if your patient have low white blood cells? So what is appropriate nursing diagnosis for a patient with low white blood cells?
They always have infections,
So
or it's hard for them to fight off infections.
the nursing diagnosis would be patient is at risk for infection related to low white blood cell count. Yeah, so that'd be that. And it just give you all a list of interventions to prevent bleeding. When y'all patients are on blood thinners, when y'all patient coagulation studies are high, when y'all patients have low platelets, they are at risk for bleeding. So you want to think about the things that will prevent your patient from bleeding out. We should not be using the regular razors for shaving. We should use an electric razor if we have to shave a patient. You want to use soft toothbrushes to brush your patient's teeth. Make sure your patient not bumping up against things, or things not in an area that your patient can actually bump up against. Because some patients who are on blood thinners, because I typically take CNAs and PCTs to clinical. CNAs, this is definitely their first time going into a nursing home setting. So one of the things they learn is that signs of abuse can be bruises, and they end up seeing patients in the nursing home like, oh my gosh, she got bruises all over her. They've been beating her. That type of thinking, where education has to kick in. No, some of these patients can be on blood thinners, and those blood thinners are too effective, where if them patients bumping up against something, it leave a huge bruise. So you want to think about interventions when your patients are placed on bleeding precautions. And they even talk about interventions for patients at risk for infection. Your patient is at risk for infection. Will it be better for that patient to have fresh fruit or fresh vegetables or cooked vegetables?
Fresh.
Why you say cooked?
I only said cook because, I mean, if it's like something on the food, if you cook it, then I'm pretty sure you're gonna like kill it off. I could be wrong.
That's correct. Because when you think about fresh fruits and fresh vegetables, everybody going in the markets putting their hands on them. And God know where everybody didn't touch, but they still touching that apple, they touching them green peppers, those types of things. And half of the time people have washed the fruits and vegetables anyway when they wash them off. And some people like to just eat them, grab and eat, those types of things. So when you are dealing with a person who have a weak immune system, one of the things you want to think about is what they eat, and you need not to be eating nothing fresh. Don't nobody need to be bringing you no plants to see you up in this nursing home because your immune system is too weak. And that's even when you think about patients who are on isolation. Most of us, when we think about patients who are on isolation, we thinking about us putting on PPE, the gown, the glove, the mask, to protect ourselves from what infection that patient have. When you're dealing with patients with weak immune systems, you need to be putting on PPE to protect that patient from what you have or what germs you are carrying. Because be clear, the human body have millions of germs on it. Right now, millions of germs is sitting all over our body. And you know, there are a lot of those germs that are sitting on our body that are pathogenic in nature. The germ that's more so on our skin is Staphylococcus. That's on the outside of our skin is Staphylococcus, but if Staphylococcus get inside of our body, it will set up infection. People who have Streptococcus, strep throat, the germ that's stuck up in your throat that then caused infection is Streptococcus. And be clear, with germs, just like all of us have our look where we're easily identifiable. Oh, she light skinned, she dark, she tall, she short, long hair, short hair, etc. Same thing with germs. Germs have a look too. That's how germs can be identified under a microscope because they have a look. Okay. But you want to be clear about your patients who are on who need to be on precaution due to a weak immune system. What are some things you should or shouldn't do? Patients with weak immune systems should not be in a big crowd. I will also encourage them, don't be around too many kids. Kids are germy. Your kids turn 2, 3, 4, 5, 1. They want to touch on everything. They're sitting on a nasty part of the toilet. They like to play in dirt. You know, they're germy. They're very germy. And you think about, it's talking about sickle cell.
Mr. Williams, everybody kids not germy.
Well, I mean, the average child is germy.
Yeah, they ain't no germy, but they get the.
They get a little messy, but they don't.
Yeah,
People that don't take care of their kids be germy.
Well, kids touch everything. So where you will see an NCLEX question asking you who are at higher risk of giving a patient with an infection or worsening a patient's infection. And if it just had the choice of kids, adolescents, or older adults, I think I'm gonna go with kids. I'm gonna go with kids. Kids are germy. I'll be around a lot of kids. Kids touch everything. You go to them schools, them bathrooms, they sitting on the nasty part of the toilet. Kids like to play in dirt. But there are parents and guardians who definitely advocate for good hygiene. Hey, you just came from outside, wash your hands. Hey, don't go on my refrigerator, wash your hands. Hey, you just came from outside, do not lay in your bed with those clothes on. So there are parents and guardians who advocate for the right thing, but kids are germy, okay. But it's some kids are a little bit neater than others, but the average kid, I remember being a child playing in dirt. I used to like to play with worms, little stuff like that. I hung with people who want to play with worms too. Okay. But it talks about sickle cell anemia. Red blood cells is sensitive to decreases in oxygen. So red blood cells are sensitive to decreases in oxygen, and it will cause the red blood cell to change to a sickle shape. Sickle cell anemia is an inherited disease. It's inherited. The red blood cells become tangled in the blood vessels and the organs, and they tend to clump up. And they put the patient at risk for a lot of things. This is how normal red blood cells should look while it's traveling through the intravascular space. With sickle cells, the sickle cells that are in the intravascular space, they actually change their form to the sickled cell, and they end up clumping up. They clump up. So to picture these cells clumping up, blood can't travel through this area, or some might be able to seep through, but not enough. So that's cutting off circulation to whatever area the cells have sickled. So depending on whatever area the cells have sickled, circulation can be decreased, where that's affecting tissue perfusion. Your different organs is not getting enough oxygen, where it's actually shutting the body down. It can potentially shut the body down. Okay. And it talks about with sickle cells, a normal red blood cell lives 120 days. With sickle cells live for about 10 to 20 days. Sickle cell is common in the African American community. African Americans, sickle cell is definitely common in the African American community, as well as the Eastern Mediterranean heritage as well. And it talks about any condition that leads to decreased oxygenation can contribute to the development of a sickle cell crisis. So some of the things that can lead to decreased oxygenation, it can be respiratory diseases, maybe a clot. Different things can lead to an exercise, where exercise makes our body demand more oxygen, body need more oxygen during exercise. You know, different things that affect breathing, affects oxygenation. And again, it just talks about that with sickle cell, it can affect multiple areas of the body. It just depends on where the cells sickle at. And it just shows some of the impact that sickle cells can actually have on the body. Because the thing you want to just picture with blood clots, with sickle cells, if it's blocking off blood flow to different areas, it's pretty much killing that area. It's pretty much causing that area to die off. Because once the body, period, if the body is deprived of oxygen for 2 minutes, some say 6 to 10 minutes, 10 minutes, you die if you're deprived of oxygen. So same thing with the different organs. If my feet ain't getting no oxygen because it's a blood clot blocking it, and especially if it's complete blockage, oh, that foot about to die quick. But like if it's a small blockage where blood can still kind of seep through, not so much. Not so much. And then it talks about how patients can get ulcers, and the ulcers, the stasis ulcers can be the result of decreased tissue perfusion to that area. Then it just talks about treatment for sickle cell. When patients do have sickle cell, the treatment will revolve around one, being deprived of oxygen can result in pain, where a patient is experiencing pain because being deprived of oxygen is causing damage to that particular area. So patient will need pain medication who has sickle cell. What are some other things you can think of that the patient would need who has sickle cell?
Oxygen.
They will need oxygen. You're not getting enough oxygen because the sickle cells are blocking blood flow to different areas. So you require oxygen.
Let's say like a serious case, could you give somebody like a blood thinner just in case like their blood could probably get through the
They might actually, some physicians may actually order a blood thinner for the patient. Patient would need fluids. Patient would definitely need fluids to hydrate them. And some patients require blood transfusions. Will somebody read this? Yeah, I don't have to read that. But just to be clear that some patients do require a blood transfusion who have sickle cell anemia. Tell me 2 nursing diagnoses for a patient with sickle cell anemia. What are 2?
Water, well, fluids. You just said one, and you just said it.
Stasis ulcers.
Well, a nursing diagnosis, like we can't make a medical diagnosis. We can't diagnose a patient with sickle cell or diabetes or anything like that. Doctor do medical diagnosis. Nurses do nursing diagnosis. We look at what you're going through and we come up with a diagnosis based on that, what you are at risk for. A patient with sickle cell anemia, if I know that this patient is having a sickle cell crisis, I know that this patient is at risk for pain. So patient is at risk for pain. Patient may not receive adequate tissue perfusion because of those sickle cells. So patient may be at risk for falls. Your blood is not flowing properly. You're at risk for falls. So it's multiple things. You look at a patient situation where you are pretty much stating this is what you're at risk for. Those are more so nursing diagnosis, where we're looking at what you are at risk for because of this disease or because of this behavior or because your shoes are untied, you are at risk for a fall. That is a nursing diagnosis. Okay. And it talks about polycythemia. Poly mean a lot. Poly means a lot. Will somebody read the first paragraph under pathophysiology and etiology?
Polycythemia includes 2 separate disorders that are easily recognizable by similar characteristic changes in the red blood count. The red blood cell count. In both forms of polycythemia, the blood becomes so thick with too many red blood cells that it resembles sludge. This thickness does not allow the blood to circulate easily. Polycythemia vera, PV, is known as primary polycythemia. Most people with PV have a specific genetic mutation. In PV, the red blood cells, platelets, and white blood cells are all overproduced, and the bone marrow becomes packed with too many cells. As this overabundance of cells spills out into the general circulation, the organs become congested with cells and the tissues become packed with blood. The thick blood and excess platelets can cause thrombosis and occlusion of vessels. PV is usually found in patients over age 50. In contrast, secondary polycythemia is the result of long-term hypoxia. Common coexisting conditions that may predispose a patient to secondary polycythemia include pulmonary disease, such as chronic obstructive pulmonary disease, COPD, cardiovascular problems such as chronic heart failure, living at high altitudes, and smoking. The body makes more red blood cells in response to the low oxygenation associated with these conditions. Secondary polycythemia is a compensatory mechanism rather than an actual disorder.
Yep, and thank you. Well, polycythemia is kind of iffy because the blood do thicken up where it can kind of appear sludgy. So a patient can be at risk for clots. So physician may actually start them on some type of blood thinner or low dose aspirin for it. The patient may also be at risk for bleeding. Patient can also be at risk for bleeding with this particular disease. The patient can be at risk for clots, and the patient is typically put on some type of anticoagulant therapy, as well as some type of anti-platelet therapy, because the platelet levels be high. But even though the platelet levels is high, sometimes the patient can be at higher risk for bleeding out. But the patient will still be placed on anticoagulants to keep that sludgy blood thin as possible, as well as antiplatelets to keep that sludgy blood thin as possible. And again, when you hear those words anti mean it's against something. So if it's antiplatelets, it's against platelet formation. If it's an anticoagulant, it's against coagulation. And coagulation is things sticking together. It's coagulating, it's sticking together. And it talks about hemorrhage disorders. It's talking about disseminated intravascular coagulation, abbreviated for DIC. Will somebody read the first paragraph?
Disseminated intravascular coagulation involves a series of events that results in severe hemorrhaging. DIC is a catastrophic, overwhelming state of accelerated clotting throughout the peripheral blood vessels. In a short period, all of the clotting factors and platelet supplies are exhausted, and clots can no longer be formed. This results in bleeding from nearly every bodily route possible. DIC is not a disease. It is a syndrome that develops secondary to another severe physical problem. Once this deadly syndrome develops, the progression of a symptom is rapid.
Okay, thank you. So with a patient who is at risk for bleeding, you know, if a patient is on blood thinners, physician probably will stop the blood thinners to prevent the patient from bleeding out. And an antidote for thin blood, and also like warfarin, because we talked about warfarin, where patients who are on warfarin, their INR should be between 2.2 and 3. But patients who are on warfarin works as an anticoagulant to thin the blood. Patients where your blood has thinned too much because of warfarin, the antidote would be vitamin K. Vitamin K works to thicken that blood. So a patient who is experiencing DIC physician may actually put them on vitamin K. Physician may put them on vitamin K to work towards thinning that individual blood. And patient may actually receive a transfusion of platelets to help the patient to have more clotting factors, okay? And nursing management, you know, the patient would be on bleeding precaution, so you need to monitor different sites, the different sites of the patient body for bleeding. Of course, if you recognize any type of abnormality, you want to report it to the physician. And it just gives you some laboratory values that you would see with a patient with disseminated intravascular coagulation, where a lot of the coagulation studies will be prolonged. And when they say it's prolonged, that means that it's high. That's what they mean. And when they say it's more so prolonged, it's high, it's elevated. And it's talking about idiopathic thrombocytopenic purpura. And this results from increased platelet destruction by the immune system. So the immune system is destroying the platelets. And with the immune system destroying the platelets, what is that doing to the intravascular space? What is that doing to the blood? So if your platelets are being destroyed, what's going on? What are you at risk for?
Is the blood thinning?
Your blood it's going to cause your blood to be thin. You are at risk for bleeding out. You're at risk for bleeding out. So some of the therapeutic measures for idiopathic thrombocytopenia purpura, what do you feel like what do you anticipate the physician will order for this patient? What do you anticipate? So I had this disease. This disease is causing my platelets to decrease. It's destroying my platelets. I have not many platelets in my body. I'm just at risk for bleeding out. What should the physician give me?
Anticoagulants and anti-platelet something.
You don't need no, what would you need antiplatelets for? Antiplatelets mean that you don't want platelets in your body. So why wouldn't I want platelets in my body if I already have low platelets? I told you all a minute ago, not only red blood cells can be transfused, platelets can too. So a patient experiencing idiopathic thrombocytopenic purpura, platelet levels will be low. So one of the things I would anticipate is for the physician to order this patient to receive a platelet transfusion. You need more platelets in your body because your platelets is low. Your immune system is destroying all your platelets. And with no platelets, no clot. No platelets, no clot. So in some instances, we need our blood to clot. I just cut myself, I need my blood to clot because if my blood don't clot, I'm gonna have to sit here all night putting pressure over this area because I'm not doing nothing but bleeding out. Okay. And signs and symptoms of bleeding, it has a box. So we talked about some of the signs and symptoms of bleeding from petechiae, ecchymosis, black tarry stool can be a sign of internal bleeding where the stool look all tarry, blood in your urine. Patients who blood is really thin, you really can bleed from anywhere. You bleeding from your vagina, I'm bleeding from my nose, your sex organs, you can bleed from anywhere when you are on them blood thinners and they are too effective. And it talks about hemophilia, which is a bleeding disorder that results from lack of clotting factors. So you don't have enough clotting factors. And that makes me think like it can be something wrong with your liver or something because your liver deals with clotting factors, but you don't have enough clotting factors. If you don't have enough clotting factors, you are at risk for bleeding as well. And to actually diagnose this, various clotting factors are reviewed. And it talks about therapeutic measures is one to ensure, one, they will actually get a patient an anti-diuretic because the patient typically lose a lot of fluid. And they will get a patient an anti-diuretic to so that the patient can retain fluid. Because we know the diuretics make you flush us from fluids, anti-diuretics cause us to retain. And patient may also receive demopressin. I was trying to pull the word up so you all can see it, but patient may also receive demopressin. And the demopressin is actually given so that the body can release more clotting factors. So a physician may actually order demopressin so that the body can release more clotting factors. Somehow I passed it. And it just talks about disorders of the white blood cells. And we know white blood cells are those cells that fights off infection. They fight off infection, they fight off them, they protect our body from allergens, those types of things, where the goal is for it to protect our body for allergens. Sometimes, again, the white blood cells don't work quick enough. And leukemia is a cancer. So you want to be clear that leukemia is a cancer. Immature white blood cells are being produced with leukemia at a fast pace. And they are typically collecting in different areas of the body. And if the white blood cells are immature blood cells, that means that they're not going to work effectively. Those white blood cells are not going to work effectively because they're being produced immaturely. So it's more so with this disease where the bone marrow is producing useless white blood cells that cannot be used. So what do I put a patient at risk for? You have a lot of immature white blood cells. What are you at risk for?
Infection.
Patient is at risk for infection. So physician may actually put them on, they need to be on some type of precaution. You need that same education. You need not to be around large groups of people. You need not to be around sick people. Don't be sniffing plants. Don't be eating fresh fruits and vegetables, because those are the things that put us at risk for infection. Yeah. And it just talks about acute lymphocytic leukemia. That type of leukemia occurs most in children. And it also talks about acute myelogenous leukemia, AML. It occurs in individuals more so over 60 years old. There's no clear cause for leukemia. They don't have a clear cause for leukemia. The signs and symptoms that emerge from leukemia, the different signs and symptoms that actually emerge from leukemia emerges due to the decrease in white blood cells, red blood cells, and platelets. So those, due to a decrease in red blood cells, white blood cells, and platelets are where the signs and symptoms come from. So you can kind of dictate what the treatment will actually be. If I have low white blood cells, what would treatment be? Patient may need to be on an antibiotic. You may need antibiotic therapy or some type of anti-infective. With red blood cells, hey, we need something for iron production. We probably put you on iron pills, or you may have to get a transfusion. And when you think about the low platelets, you are at risk for bleeding. You may have to get a transfusion. Okay. And of course, with any cancer, chemotherapy, radiation, and surgery are options. With leukemia, bone marrow transplant can be an option as well. Patient can't qualify for a bone marrow transplant. But when patients are receiving cancer treatment, that chemotherapy, radiation, you know, you want to monitor them for signs and symptoms, not signs and symptoms, for side effects of the radiation, as well as the chemotherapy, because chemotherapy weakens individuals' immune system. So this person already kind of got a weakened immune system. Chemotherapy will weaken it further. And it's talking about multiple myeloma. And multiple myeloma, when you hear oma at the end of the words, I'm definitely thinking cancer or tumor. The multiple myeloma is a form of cancer in the plasma cells. It's a cancer of the plasma cells in the bone marrow. And this disease more so affects the bone, the immune system, red blood cells, and kidneys. With this disease, multiple myeloma, because the mile also makes me kind of think bone, muscle, that type of thing. But with this disease, the bone loses calcium and it leads to kidney stones. Because typically, if your bones are breaking down or whatever, and you losing all that calcium, you can develop kidney stones. If you're consuming a lot of calcium, it contributes to kidney stones as well. One of the main complaints with multiple myeloma is skeletal pain. Most of the patients complain of skeletal pain. And with diagnosing multiple myeloma, patient will have a C-reactive protein in the blood that's elevated. And that's how they will actually diagnose it. And therapeutic measures is to more so manage the disease and the actual symptoms with multiple myeloma. And it's now talking about lymphatic disorders. And a lymphatic disorder is Hodgkin disease. It's cancer of the lymph system, and it is curable. So Hodgkin disease is cancer of the lymph system. It's curable, and typically the patient with Hodgkin disease has painless swelling and one or more of the common lymph node chains. And you may see something that appear like this for the patient who actually have Hodgkin disease, where they got that painless swelling and a chain of the lymph nodes. And it's the patient where you can see patient had radiation. So the radiation was definitely effective in shrinking the cancer, because that's one of the things radiation can do. Radiation can shrink the tumor, and it also kills tumor cells. And the patient will require a lymph node diagnosis, not diagnosis, a lymph node biopsy for diagnosing the actual disease. And it's talking about non-Hodgkin lymphoma. With non-Hodgkin lymphoma, the individual prognosis is low. So it's high chances that the individual will actually expire. With non-Hodgkin lymphoma, the body produces too many abnormal lymphocytes. It's producing too many abnormal lymphocytes. And you know, a lymphocyte is a component of the immune system. Non-Hodgkin lymphoma is common in middle age and older adults. The individual will present with enlarged nodes, and typically a biopsy will actually be used to confirm the disease. And treatment revolves around chemotherapy, radiation, as well as surgery. And it actually gives you all some comparisons between Hodgkin disease and non-Hodgkin lymphoma. And one of the key differences when looking at it, where it do tell you Hodgkin disease, more so for a younger population, as well as for those over 55, non-Hodgkin lymphoma is definitely for those over 50. You want to keep this in mind, that Reed-Sternberg cells are present with Hodgkin disease, and they're actually absent, in non-Hodgkin lymphoma. So that's something you want to know for testing purposes, that Hodgkin disease will present with Reed-Sternberg cells. It's talking about splenic disorders. And again, the spleen functions to recycle red blood cells and store platelets and white blood cells. The spleen do help fight some infection. Will somebody read the second paragraph right here? If the spleen enlarges.
If I'm gonna read it. I don't know if you hear a piano in the back. That's my little brother. I apologize ahead of time.
No problem.
But if the spleen enlarges markedly, the condition is referred to as splenomegaly. Other times, the spleen may or may not be enlarged, but the function is out of control so that too many RBCs and platelets are removed from the peripheral circulation. Sometimes the spleen is not able to perform its job because of bleeding into the pulp of the organ, which makes it useless. Bleeding into the spleen can occur from various illnesses or from trauma. Regardless of the nature of the malfunction, one treatment option may be splenectomy.
Okay. And when you think about like the complications that may result from having a spleen removed, you want to think about the functions of the spleen. That's for anything. When you want to think about how's the body or is the body going to function without this organ, you need to think about the function of it. So we know with the spleen actually store white blood cells, it store platelets, those type of things. It recycle red blood cells. So living without a spleen is possible, but it still will have an effect on you. If you have no white blood cells stored in the spleen, which you also get white blood cells, blood components from the bone marrow, you might be at higher risk for infection. If the spleen stores platelets and now you have no spleen, although platelets come from the bone marrow as well, you may be at risk for bleeding out because you don't have enough platelets. Okay.